Hi, my name is Murray Arlen. I'm a periodontist working in full-time private practice in the Toronto area. And I want to thank Dental XP for inviting me to do our second presentation. You can check the archives. We've done a previous presentation on narrow diameter implants. Now we're going to go to the opposite spectrum, and I'm pleased to do this presentation on immediate implant placement in molar sites and highlight the use of very wide diameter implants, some that are fairly new. In terms of a quick disclosure, as I mentioned, I am in full-time private practice in my 30th year. I'm not an employee of any commercial entity or university, don't get any grants. I do utilize multiple implant systems in the office. I work with a team approach. I don't do my own restorative work. All of my images that I'm going to show you have not been touched up in any way, and I really do show the good, but I also am not afraid to show the bad and the ugly, because we all learn sometimes from our mistakes or imperfections, and in the end it's all about a learning experience for you. The way I'd like to organize this presentation is to divide it into three sections. A brief review of looking at the overall picture of immediate implant placements, the advantages and indications. We're going to have a quick look at some of the evidence for the efficacy of this procedure, both looking at the literature, but I'm also going to share some of my personal experience with you. And of course, then we'll show you some interesting case presentations. And what we'd really like to do when we're looking at immediate placement in molar extraction sites is improve upon the kind of result that you see here, where we have an implant that's far too narrow to be a standalone restoration for a molar site. And I will follow up and show you the 7-year follow-up on this case very shortly, but this is really not what we like to see. This is maybe a little bit better with a wider diameter implant, but this was an immediate placement into the mesial root, not giving an ideal alignment for the emergence profile of the tooth. Same situation here when the implant is placed in the distal root. So we want to see if we can improve upon this non-ideal type of situation. And we want to avoid this situation where we attempted here to do an immediate implant placement in the middle interradicular bone of a molar site, but we're not able to get initial stability with what I'll term standard diameter implants of 6 millimeters or less. And I'll introduce in this lecture today a newer design of 8 to 9 millimeters in diameter that's specifically designed for immediate molar extraction socket placements, where it's very rare that we have to abort an immediate implant placement due to lack of initial stability. An implant, something like that can be used in this situation where we have a molar with minimal bone coronal to the sinus area, and if we can have a wide enough implant of 8 to 9 millimeters in diameter, even if it's only 7 millimeters in height, and be able to capture enough circumferential bone with lateral contact and stability, not depending on apical stability, to be able to get our initial immediate implant placement with good initial stability. So that was a quick little intro just to whet your appetites for the case presentations that will follow. But I'd like to give a responsible presentation. So let's back up a little bit and just look at the subject of immediate implants in general, not just molar sites and not just immediate extraction sites, but there are a lot of advantages and preferences for both the patient and the dentist. First of all, we can't underestimate how much patients appreciate doing all the treatment in one appointment, less two-stage grafting, reduced number of visits, time, surgery, and as a result of all that, really increased patient acceptance and perhaps more work for us to do, so it's to our benefit as well. I also believe with the immediate extraction socket placement technique, we do have potentially improved implant positioning, better implant size, larger size, perhaps even reduced tissue resorption and improved aesthetics when we can get that implant in before we suffer that normal post-extraction ridge resorption that we inevitably see if we're doing a delayed implant placement. However, immediate implant placements are sometimes challenging or contraindicated. Sometimes the socket morphology will not allow us to get initial stability or place the implant position properly. Although, as I say, I'm going to introduce a wider implant system where I think we can obviate most of that. Sometimes we have infection, periapical infection, or circumferential bone defects that may be a contraindication to immediate placement. And sometimes in very thin soft tissue areas where we're worried about recession, we may decide to do it as a staged approach. And sometimes the immediate implant placements are a little bit more challenging surgically, and they're not necessarily slam dunk easy surgical procedures in all cases. Let's look at the evidence now for the efficacy of immediate implant placements. And here I'd like to show you a few pertinent articles in the literature and also share with you some of my personal experience. But I think it's worth reviewing what really is evidence-based dentistry. Yes, it is the best available evidence, the published literature, but it's not just that. It's also your clinical judgment. And it's also what's right for that particular patient. So it's really all three of these aspects combined that gives us what we could term evidence-based treatment. So let's start off by looking at a few articles in the literature. And I'd like to back up a little bit because we will be talking about wide diameter implants. And let's just look at wide implants in general, be they immediate or non-immediate. In the early studies when wide diameter implants were first introduced, there were reports of higher failure rates and a higher incidence of crestal bone loss. And a lot of that was probably related to the early learning curve and perhaps being too aggressive, thinning out the bone too much by trying to get in a huge wide implant, perhaps too wide for that particular site. And this is not my case, but I can show you similar cases where I had my learning curve of a wide diameter implant that was perhaps too wide for this case. And you see there's a soft tissue fenestration with the implant poking out through the tissue. So there was a bit of a learning curve with wide diameter implants. However, subsequently we have many studies that have shown good results with wide diameter implants when used appropriately. The next point I'd like to just talk about a little is when we do immediate implant placements in particular, should we use a submerged approach or a transmucosal or non-submerged approach? And indeed, many studies show good results with submerged protocol, but there are also many studies that show good results with immediate implant placements without burying the implant with a transmucosal approach. So I think that either one can be done effectively if the case is chosen and handled properly. Let's move on to the subject of immediate implants. And what are the survival statistics with immediate implants? We're not talking molar sites. We're talking immediate implants from all areas of the mouth. And we have many studies showing greater than 95% survival or success rates, depending on the study, both prospective studies and retrospective studies. And I myself will show you some of my results on placement of over 2,200 immediate implant placements. Next, what are the stats on immediate placements, but specifically in molar sites? There are fewer studies, but there are several, which I've listed here. And we're just going to look at a few of these studies very briefly, and I will also report later on my own personal statistics with over 220 immediate molar implant placements as well. So here's one study done with 82 wide neck Straumann implants, non-submerged protocol in this particular study, showing 100% not only survival rate, but good soft tissue as well. Now, Fugazzotto has published very large numbers of implants in various studies. This one was on maxillary molar sites, immediate placements, with almost 400 Straumann regular or tapered implants. He utilizes pretty much a submerged approach with guided bone regeneration in most cases, and had, as you could see, 99.5% success rate. Well, what happened to his mandibular molars? Well, that he's saved for a different study, also published fairly recently, again, 341 in the mandible, again showing you excellent survival rates. So Fugazzotto and others have shown that you can get very good rates in immediate molar implant placements. This again is another recent study, different implant system, again a non-submerged protocol in this particular study, smaller number of immediates, 32 immediates in this case, again showing 100% success rates. So we have a number of studies that show excellent rates. Now it is worth mentioning one or two studies done perhaps a little time ago, perhaps earlier in the learning curve, where the results weren't as good. This one by Schwartz, Arad, and co-workers showed an 89% survival rate. And Fugazzotto and others refer to this study and point out this was perhaps lower rates due to perhaps an earlier learning curve. Often these implants were not placed optimally in the interradicular bone, but in one of the roots. So I think, again, with the technique done properly, we do have pretty good evidence that we can get pretty good survival rates. And again, we'll introduce a newer implant system called the Max implant that have implant diameters of 8 to 9 millimeters with a tapered design specifically designed for immediate molar implants. The only implant of its kind that I'm aware of specifically designed for this. And this is a new implant, so this is some of the data submitted by the researchers where studies have been going on for up to 4 years, showing on a short-term basis with a relatively small number of this particular Southern Max implant design of 100% success. Well, I always like to show my personal success rates and survival rates because when we read published data, typically the people who publish are the all-stars of the implant industry, and we'd like to know that can we translate those results into our own everyday practice. And I like to share my personal results with you as well because I do document every single implant I've ever placed. And we're up to about 9,400 implants now over a period of 20 years. And I have a special computer program to track those. Now, for those of you who don't know what a life table is, I throw it up here, but I'm not going to explain the details. Let's just say that if you look at this case where for example, a person's done 100 implants over a period of 5 years, let's say there's been a total number of 10 failures, you could call that 90% survival rate, but you could call that an absolute survival rate calculation. The life table shows 81.5% cumulative survival or success rate. And then just really what that ends up being, it's a statistical prediction of what the true survival rate will be when all implants that you've placed have been followed, in this case for a minimum of 4 to 5 years. So it's predicting over time some of these cases you only did a year ago may fail within the next 5 years. Again, it's a more statistical prediction. This is a sample of my implants where I had at this point done 9,153 implants, and if we did an absolute survival rate calculation, it would come out to 95.08. But applying this life table analysis, after 15 years and up to 20 years, there was no change. I have a cumulative survival rate of 91.3 at 20 years. So this predicts that I'll lose close to 4% more if I follow many of these implants for another 10 to 20 years time from now. But the reason I'm showing this is let's compare the statistic survival rates of all protocols and compare that to just the immediate implant placements. So of these 9,153 implants, 2,244 were immediate implant placements, and you can see that the absolute survival rate is within 0.2 of a percentage point of all protocols, and the cumulative survival rate is in fact about 0.7% higher. So we could say statistically that we're getting at least equivalent survival rates with immediate implant placements compared to healed sites. And this again is looking at all sites of the mouth. But let's look at molar sites, because the topic for today is immediate implants in molar sites. And on your left, on the dark blue or the medium blue graphs, what we're looking at is a breakdown really of molars on the left with all implants placed, and on the right in purple we have all immediate molars that have been placed. And what you can see is some interesting trends. First of all, if anything, there's slightly a lower failure rate with immediate molar implant placements compared to molars in healed sites. Second, the breakdown here, what it shows is whether it's all molar implant placements or all immediate molar implant placements, we have a tendency for slightly higher failure rates in the second molar sites compared to the first molar sites. And again, I don't want to get too technical into the numbers, but basically that's the trend that it shows. So it's comforting to know that we can expect equivalent success rates in molar sites. We might have a little bit higher failure rate in second molar sites compared to first, and I think we might anticipate that because typically second molar sites, whether it's the lingual mylohyoid undercut of the mandibular or a pneumatized sinus in the maxilla, more often than not we're dealing with a more challenging bone compromise situation in second versus first molar sites. Again, if we just kind of lump all the molars together, you can see again in a more simplified way we have, if anything, slightly better survival rates with immediate molars compared to healed. So I think it's fair to say that we have pretty good evidence that immediate sites work and immediate molar sites can work well as well. In terms of my personal experience with this large diameter Southern Max implant, I've only been doing it for a year. I did have 2 failures which I ascribe to surgical error, my early learning curve. And so in the short term, I think we have pretty good evidence that these techniques can work. Let's move on to the fun part, case presentations. And I think I'd like to show you a little bit of a total cross-section. And let's start actually with compromised results where we haven't done an immediate extraction placement. It's a healed molar site where we've been forced to use a narrower implant. And here's a case where we've lost the first molar, the sinus is pneumatized, patient doesn't want a sinus graft, they're satisfied with just a single tooth and leave a distal diastema. And in fact, this was the best we could do for that patient. Not ideal, but for this patient it was good enough. Here again is something you should not do, placing a narrow diameter 3.3 millimeter implant as a standalone posterior restoration. There's a long story to this patient. This is not what I wanted to do, but I will admit with the patient's informed consent we did proceed. And you can see here it being restored after 3 months, and lo and behold, after 3 years the patient shows up and the implant has fractured. Now remember that case I introduced at the beginning, and I say we'd revisit it? So I want to show you what happened to this case, but now it's 7 years later, and you can probably guess what happened. Actually, nothing happened. It was fine. But the point is that a certain percentage of these are at risk to fracture, and it's something we want to avoid. In fact, you'll notice that the patient actually came back because she needed another extraction and another implant. And as you might ask me, yes, we did try to convince the patient to redo the original crown and do the 2 crowns splinted together, but she declined. And here's that case clinically. Now this is a case that is a healed site placement where the ridge was quite narrow in the orofacial dimension and too wide to place a big, huge implant, a big, huge crown on one narrow diameter implant. And all of these cases, they've all been given their options to augment the thickness of the bone, and you'll just have to take it for granted that all these cases the patients declined these augmentation procedures. Well, in this case, fortunately, we had enough mesiodistal space that I could fit in 2 3.75 implants, and the case worked well with sort of 2 small bicuspid sized teeth splinted together, but to me this is not the ideal. Patient is paying more for the treatment. It's more difficult for the patient to clean. And if we had the luxury of doing an immediate extraction socket placement here, we could just put in 1 large implant in the middle. It'd be more cleansable, more aesthetic, and less costly for the patient. Let's look at the next category of good results with immediate molar implant placements. But here we're going to show you some cases where we use what I'll define as narrow diameter, meaning 6 millimeters or less. We're going to get to those big, fat 8 to 9 millimeter ones a little later on. And here, being as I am, I like to categorize everything. So within this category of at the top you see good results, immediate molars, narrow implants is the common theme for the next 7 subcategories I'm going to show you. Let's first look at maxillary implants, where we have an implant being placed in an immediate extraction site being splinted to another implant that's being placed in a healed site. This is significant when you're thinking of the prosthetic treatment because more often than not the implant is placed in one of the roots, not in the interradicular area. And this has advantages of being able to get easier, predictable stability with narrower implants, a smaller peri-implant void. It has a potential disadvantage that you have to make sure you have enough interradicular bone, that you're not getting a lateral implant bone dehiscence. And because you're putting one of these implants in the molar socket, the rest of that molar tooth is unsupported, and it can end up being a pontic, for example, if you're splinting that to another implant distal to the extraction site. So here's an example where we're going to remove this second bicuspid and the 2 molars, and you'll forgive me, some of my slides have the international numbering system that we use in Canada, but what we have here is a healed site in the first premolar position, an immediate placement in the single-rooted second premolar position, and 2 immediate implants that went into the distal root of the first and second molar. And you can sort of see, because we have the implant in the distal of the first molar root, on the mesial we have that unsupported section that can be restored as a pontic, which works well when you have this category of splinting to other implants. Unfortunately, a lot of restorative dentists and laboratories don't realize that they should perhaps try to contour this as a pontic. In this case, it looks like a molar that's heavily cantilevered. Aesthetically, it's not an issue being in the posterior part of the mouth, but it'd be nice to contour this as a pontic as opposed to an overhang, so perhaps you have less food impaction and you have improved aesthetics. Here's another case in this category where we initially were planning to save the first molar. You see there's decay on the distal. We did a healed site placement in the upper right second molar, and then after we changed the healing abutment to give the doctor access for the decay on the distal of the first molar, at that point the decision was made to remove the first molar. So now we're going to have an immediate placement in the first molar site, and we're going to want to splint it to the previously placed implant in the healed site. Here we're going to try this time to put it in the middle, because I don't want to create a pontic space here. I want to try to have two molars splinted together, and I know for mesiodistal spacing, if I can get that molar mid-root, we're going to have a better prosthetic result. Here's after several months of healing, and here's 6 months after the restoration is done, and here's 3 years after the restoration was done. And you can see our contours here from the palatal view, and here from the buccal view. I'm sorry, we've cropped off a portion of the second molar. We have more normal size looking molar teeth without the pontic. So next category in this category B of good results, immediate molars with narrower implants, is the same situation but in the mandible instead of the maxilla. Here we're going to remove this bridge. We're going to do an immediate implant in the previous pontic site, and that's the healed site, and we're going to do an immediate placement in the distal root of that extracted molar. Obviously, I'm going to go in the distal root as opposed to the mesial root, so we can have some space in between, and we calculate that we can restore this as a 3-unit bridge with the previous mesial root site of the extracted molar being the pontic. So that's after healing. That's in fact what was done. And here we have what looks like a 3-unit bridge. So these kind of cases can work out extremely well. Another little category is, what about when we have to remove all the teeth? And I often do these kinds of cases, believe it or not, as full mouth extraction and full mouth immediate implant placement. And sometimes, as in this case, the lower distal implants are in the molar extraction sites on the patient's left. This would be in the distal root of the lower left first molar, and on the right in the distal root of the lower right first molar. And the others were single root placements. Here is another case. Similarly, as part of this full mouth reconstruction, on the lower left we have an implant in the mesial root of the first molar. That's the distal implant there. On the patient's right, the distal implant is an immediate placement in the distal root. So we don't always have to go intraradicularly. We can often go in the socket itself if we have other implants we're splinting to, and we have more flexibility in creating pontics where we need them and make it all work out prosthetically. Now here's another category under the B section where we have two implants, both immediates, splinted together. The previous one was an implant placed in a healed site, splinted to an immediate. Here we're going to do two immediates, and where do we put these implants? In the socket, interceptally. Well, we're going to remove these two molar teeth, the lower left first and second molar, and here we place the first implant in the mesial root of the first molar, and again in the mesial root of the second molar. And anticipating that again we can do probably a 3-unit type bridge with a pontic in the middle. As it turns out, the way this restorative dentist and this lab chose to restore this case, they've kind of over-contoured the aspects of both crowns, creating a 2-unit restoration with a rather large interproximal space between. And this may be perfectly satisfactory for 99% of your patients. If this space or food impaction problem was an issue, perhaps utilizing a pontic would have been a better restorative decision. Now here again is another category as in the maxilla, same as the mandible. In this case, we already have a missing tooth, and you see the pneumatized sinus here. Again, planning in advance, if we were to remove these teeth and wait, I think we would not be able to do an implant in the molar site without a sinus graft first. By doing immediate placements in this case, both in the bicuspid anteriorly and in the molar posteriorly, we were able to manage to capture the buttress of bone in the bicuspid placement and sneak it along the distal wall of the sinus without the need for sinus grafting. Probably when you think of immediate implant placements in molar sites, you think more often of the single implant, the single molar, which is perhaps the most common situation. And here again, in the maxilla, we more or less have two categories. Again, whether you place the implant in one of the root sockets or whether you place it mid-socket intraradicularly. The potential advantage, like before, of going in the socket, it's easier to get initial stability, smaller peri-implant void to deal with. And the advantage when you go in the mid-socket is that you probably have a better implant positioning. Potential disadvantage of going in one of the root sockets is you probably have compromised angulation. You may have an unsupported portion of the tooth if you're not in the middle of the tooth. And the possible disadvantage if you go mid-socket is that you may not be able to get good initial stability. If you've drilled away your interseptal bone, there may not be enough stability depending on the type of implant, diameter and shape you have. And sometimes if you put the implant right in the middle of a molar socket, you've got a rather large peri-implant void to deal with. So let's look at the first category where we're doing a single maxillary immediate molar placement, and we're going to put the implant in one of the sockets. And here's an example of a molar to come out. The implant is placed more so in the distal position. And while the results are really not too bad, you see the healing here at 4 months, we do have an implant that is angled. Honestly, with an implant of 5 to 6 millimeters, I'm not worried biomechanically that we're not exactly along the long axis of the tooth. But we may have some issues here with the interproximal anatomy, with a larger interproximal embrasure mesially that may be more prone to food impaction. Generally a good result, but perhaps not optimal. Clinically, it looks quite nice. What about when we're doing the immediate maxillary single tooth restoration and we are able to place the implant more in the center, as in this case it's more in the center. This one's a bit shallow actually, so we have a short root, but you can see that we have a more optimal positioning of the implant, even though we probably have too much tissue here and a short crown. What about in the mandible? Again, same two categories. What happens when you place the implant into one of the molar sites? Here we're going to place it in the mesial root of this molar, and you can see that we try to distalize it as much as we can, and perhaps you might end up with a bicuspid size restoration. In this case, this was a wide diameter implant that we were able to put a tooth that was almost a full molar size, and the patient didn't have an opposing second molar, so it was a very satisfactory restoration. Here's again just another similar case with a different implant design. And again, this case, the tooth is closer to bicuspid size. So sometimes we have to accept a smaller restoration size, but that's perfectly adequate in many cases. Well, what about when we can put the implant right in the mid-socket? And here's a case where we're going to do that. And again, all these implants are what I'll call narrower, meaning 6 millimeters or less. This is a 6x13 where I managed to get it pretty close to mid-root. And we have what I think most of us would feel is a pretty acceptable result. And we have very nice clinical results as well. The problem here is we can't always get good initial stability. And sometimes we do run into some non-ideal results when we're dealing with these implants that I'll call narrower, i.e. 6 millimeter diameter or less.